Welcome to the Committee on Health, Human Services, Finance and Policy. Today is February 28th. We do have a quorum. First on our agenda is Senate File 153. Senator Westrom. Senator Westrom, you are up first on our agenda today. Welcome to the committee.
Thank you, Madam Chair.
And Senator Westrom, I'm going to have Senator Jensen move Senate File 153. The motion, when we have finished debating, will be to send it to the floor. Please proceed with your testimony.
Okay. Madam Chair and members, thank you for the hearing, and great to be here. With me is two testifiers that I want you to hear from. Alexis Lotka, who's from the Morris area. Give you a little bit of history. About a year and a half or so ago, Alexis and her mother and family had contacted my office to meet about a rare disease that she lives with. And so to make it real short, it worked out when I was at some other meetings in the Morris area one evening after school. Actually, in the evening, we were able to meet up at a local church in Morris, and she was telling me about her adrenal insufficiency disease that she has to live with and has battled it and conquered it quite well and lives a very normal life. But the concern that her and her family live with is others not knowing how critical it is for her to have medication and treatment if she was to have an issue or an episode where she wasn't able to administer it to herself. And so what the bill does here, that Alexis and others in the state, Senator Frentz is co-author on my bill, and he has a similar bill. And for persons with an adrenal insufficiency or other rare diagnosis like that, the simple solution that they are asking for is that EMS would have this as part of their guidelines and express authority to be able to use the prescription and the medication of the patient that they might be treating or have the ambulance call for, so they could administer that prescription that the person themselves usually administers to themselves. Because time is of the essence and more harm would be done getting and waiting to get to the hospital or the clinic, it's a very common sense solution that they can use the patient's prescription, and there will be protocols and processes that they would know about. And Alexis, who you will hear from just momentarily, has done, and her family have worked hard in the Morris area to work with the ambulance service and other paramedics so they know of Alexis's condition, but they would like it to be more natural and part of the system statewide. And so that's why we have the bill here. Also here is Darlene from Missouri, and she is working on this effort and has worked on it in Missouri. It worked that she was in town, and we could couple this hearing with another visit she has here with an event at the U of M on rare diseases tomorrow. And so, Madam Chair, it's great that we're able to hear from such valuable proponents of this effort that we can be a part of here in Minnesota. And so the purpose of the bill today is to pass it to the floor, but to pass it here in Minnesota. We had it in the bill last year in the finance bill that was vetoed. And so we want to make this happen here in Minnesota. And Madam Chair, we do have agreement on an amendment later, but I would like to have the testimony first, and then Tony from the EMS Regulatory Board is here to offer brief comments after Alexis and Darlene are able to tell you additional support of why this bill is so important.
Alexis, welcome to the committee. Please state your name and proceed.
Thank you, Madam Chair and Committee. My name is Alexis Lutka, and I'm a 14-year-old currently residing in District 12A in West Central Minnesota. Another thing you could say about me is that I have a rare disease called adrenal insufficiency. Adrenal insufficiency is a disease where my adrenal glands do not produce enough of a certain hormone called cortisol. To compensate for the absence of this hormone, I have to take a supplement hormone orally. And since cortisol is usually regulated based on the amount of stress a body is under, I have to take extra oral medication if I am stressed, have an illness, or if I have an injury. If I have a very serious injury, get a concussion, pass out, or can't keep pills down, I must have the medicine injected into me. In case of medical emergency, I carry a kit that contains my pills and injection. Wearing a medical alert bracelet is another precaution that is taken to ensure that EMS personnel are aware of my condition in the situation that I would not be able to speak. In most cases, if I would need my injection, I would not be able to administer it to myself. As a result of this situation, my teachers, friends, and family members have been taught how to administer my medication. Almost all of these people who have been trained to give me my shot have little to no medical background. And right now in the state of Minnesota, my 7-year-old sister, who has no medical background, can administer my medication, but a trained EMT cannot. I travel to many different places around Minnesota for various reasons. My local ambulance service is working on creating medical protocol for me, but this will only keep me safe in a small community. And I want to be able to be independent throughout the state. And to do this, I need the committee's help. You can help me by getting this legislation passed, and in my mind, this no-cost, life-saving bill is a no-brainer. If you have any questions at this time, I will respond to them to the best of my ability.
Thank you very much. And Darlene Shelton, I have next on my list.
Yes. Hello. Thank you very much for allowing me to be here. Darlene Shelton, actually from Missouri. I am the president of the Danny's Dose Alliance, and it's an organization that our family actually formed when we realized of the current old protocols that we're dealing with across the United States that prohibit our paramedics from administering life-saving medications that aren't on the ambulance. Basically, any medication not on an ambulance. Of course, if it's not life-saving, it doesn't really matter. It's the life-saving ones that we feel are the most important. And when we realized that we have the number of people that we have with a variety of rare diseases that depend daily on prophylactic therapy that they do themselves in their home, it's astounding. So for Minnesota, you have over 360,000 individuals, not including their families, that carry life-saving medications that we know of so far. And that's just data that I've collected from being part of the rare disease community and meeting these families and taking upon ourselves to learn about this. We started in March of 2015. We're not very old. We are not a political science family. I do accounting. My son and daughter-in-law are engineers. My husband is a contractor. And our very first day that we ever visited our own capital was March 11th of 2015. We took the family. We showed up and said, hey, there is a problem. We don't know how to fix it, but we know it has to be fixed. The Danny's Dose Alliance was formed shortly after that when we knew that it was nationwide. No one was doing anything, and we had to do it. The way we found out about this story was a good friend who has severe hemophilia B, meaning he does not clot. A grown man that had been self-infusing for years, had a car accident, broke his right wrist, and had a blow to the head. So he could not infuse himself because he didn't know how to do it with his left hand. The ambulance showed up. The paramedics said, we're sorry. We cannot administer a medication that's in your automobile. It didn't matter that he had orders from his physician that proved the dosage amount. And he was still alert. He was telling them, I need that medication. I've had a blow to my head. I could be having a slow bleed. So they said, we'll just get you to the hospital faster. Another reason this is so vitally important, getting you to the hospital faster does you no good. They have exactly the same protocols. They will not administer a medication that's carried in those doors. This leaves patients at a loss. In very vital situations like adrenal insufficiency, bleeding disorders, pulmonary hypertension, it means death. And there are people dying across the United States. I hear about them. It breaks my heart. I want you to know right now in Minnesota, you have a baby girl in a hospital with adrenal insufficiency in a coma because the family was not trained to do the injection. They called the ambulance. I am not blaming the paramedics. They didn't have the training yet. The family wasn't trained yet. It's a combination of a bad situation. The medical advisor said, just get her to the hospital quicker. She is currently in a coma. Because of HIPAA, I think she's still alive. I don't know her complete condition, but very likely she has permanent brain damage. This cannot continue to happen. And I know that you have thoughts about, okay, liability. How are we going to do the education? How much is it going to cost? Where are we going to get the money for cost? We've been working on this for 3 years. And when I say working on it, I attended every other state EMS meeting in Missouri, and our state stepped up. We're also working with HRSA, American Academy of Pediatrics, the National Association of EMTs, the National Association of EMS Physicians, the National Association of State EMS Officials, and EMS for Children. They've invited me to be on their advisory board to be a voice for the rare disease community. They have recognized this is an issue. It's being worked, a solution from the national level as for template protocols are being worked on, but it's too slow. We've got to get our states to step up and do what's right. But we're working on education. Education does not have to cost anything. Our Missouri bill was a zero fiscal note because you have hospitals, you have pharmaceutical companies, specialty pharmacies, rare disease groups that all have trained nurses that will come and do this education. Missouri's had 3 grants since 2016. There's some grant money out there too. So it doesn't have to cost. A little bit of additional administrative cost, but that's not really anything major that's going to be a budget issue. So I want you to know, I'm not this lady from Missouri who's walking in here and dumping something in your lap and saying, fix it. I want you to know you have a lot of organizations that are working together for a good solution to help our EMS because we love them. They are our heroes. They save our lives. And we're here to be part of a complete solution.
Okay. Thank you very much. We have Mr. Tony Spector from EMS. If he could join us, ladies, if one of you would allow a seat for Mr. Spector. Thank you. Welcome.
Thank you. Madam Chair, members of the committee, good afternoon. My name is Tony Spector. I'm the Executive Director of the State Emergency Medical Services Regulatory Board. The the EMSRB is a 17-member board comprised of individuals including emergency physicians, and one of our emergency physicians serves as the EMSRB State Medical Director. This bill and the companion House file has been discussed by our physicians as well as the members of the Medical Direction Standing Advisory Committee. That's a standing committee of the EMSRB comprised of emergency physicians from throughout the state. And I speak on behalf of our state medical director as well as the MD-SAC group. And by the way, the MD-SAC group convenes tomorrow at 9 a.m. The EMSRB medical director and the physicians do not oppose this legislation, or the bill rather, with the exception of paragraph B, as in Bravo. There is opposition to paragraph B. The physicians take the position on our board that patient care plans are really the responsibility of the primary care provider, and they should be crafted by the primary care provider. They certainly can be shared with the ambulance services, and that does happen. It's not unusual. In fact, if I recall correctly, there was a patient in southeastern Minnesota who had a left ventricular assist device, and there was a patient care plan that was shared by the physician with the ambulance service. And so as it relates to paragraph A, with the adrenal insufficiency and other rare conditions, that medication, it makes sense. It certainly does. And the MSRB is looking forward to crafting guidelines under the stewardship and guidance of our Medical Direction Standing Advisory Committee that we can share with ambulance services throughout the state. One thing I do wish to identify in this bill is that it is not limiting simply to ambulance services. It's EMTs, AEMTs, and paramedics. And so we have AEMTs and paramedics serving in other functions, for instance, on fire rescue vehicles. We have police officers who are EMTs. We have EMTs who are working in standalone primary urgent care facilities. And so this could create some interesting opportunities. But I'm not a physician, and I certainly don't play one on television. And so I look forward to the board and the physicians working to craft guidelines that make sense and that can be implemented. And again, our goal is to save lives.
Thank you, Mr. Spector. And I do believe, Senator Westrom, that the A1 amendment that members have in their packet does address paragraph B.
It does, Madam Chair, and we would be supportive of somebody moving that, and I just wanted it on the record, and we've discussed this. Part of paragraph B was also to try to push things along. We feel we have a good arrangement, support, as you've heard from Tony, and I've met with the ambulance service, and I think everybody's wanting to row the boat as quickly as we can in the right and same direction. And so we are comfortable that everybody is working in good faith to make this happen. And I think as everybody gets to know more and more about it, it is common sense. And I think we'll look back at this as a great milestone and a great step in the right direction for saving lives.
Okay, thank you. Senator Rosen moves the A1 amendment. All those in favor say aye. Opposed? Thank you, Senator Rosen. Senator Westrom, questions from the committee on this bill. Senator Rosen.
Thank you, Madam Chair, and thank you, Senator Westrom. This is a very good bill, and I appreciate you bringing this forward, and especially to your young testifier. She did an amazing job. She looked us right in the eyes, and it was very moving testimony, and thank you very much. I was wondering, this is a technical question, Senator Westrom,
okay,
if this language should be amended to include community paramedics, or if that advanced EMT, the AEMT, would include that. Is that something that we should look at?
Mr. Spector?
Thank you, Madam Chair, Senator Rosen. In order to be a community paramedic in Minnesota, the prerequisite is that the individual must be a paramedic. And so the fact that if it doesn't include the language community paramedic, it would still cover every community paramedic throughout the state.
Okay, thank you. And Senator Eaton.
Thank you, Madam Chair. My question is, there's very few, but there are still some ambulances and first responders that don't carry naloxone. Would this bill pertain to that, as if the family had the naloxone on hand for an opioid overdose? We've had instances where the paramedic wouldn't use it and didn't have it on hand, so they just said, well, we'll get them to the hospital. Well, those few minutes make a big difference with an overdose.
Mr. Spector, to the naloxone question.
Thank you, Madam Chair. Senator Eaton, excellent question. It's a technical question, and I don't know the answer. This would be the language here addresses prescription medication or a rare condition that requires emergency treatment. I'm not sure if an opiate overdose would fall under the definition of a rare condition. Having said that, however, I believe that there would be room for certainly trying to do something so if a paramedic or an EMT, an ambulance service doesn't carry naloxone, how can we go about addressing that? With opiate overdoses, obviously, getting the opiate antagonist on board in a timely fashion is very critical. Equally, if not more critical, is maintaining a patent or an open airway throughout. There are situations where, anecdotally, it's been brought to my attention where an EMS or law enforcement officer has perhaps 2 doses of naloxone, delivers both doses, and it wasn't effective, and the 3rd or 4th is required to maintain that patient, artificial respiration, ventilation, to maintain that patent airway until a higher level of care can arrive, will do wonders in terms of ensuring that that life is saved. So it may be, is it related to this? It's certainly possible, but there may be some additional work that we can do to ensure that if an EMT is approached by someone with naloxone, how do we make sure that we can deliver that life-saving medication?
Thank you. Anything further, Senator Eaton?
Thank you. We've done our best to try and get it in everybody's hands, but there are still some small communities who don't have it yet.
So, thank you. Further questions from the committee? Okay, thank you. Senator Kiffmeyer.
Thank you, Madam Chair. I just want to say how we had our testifiers. I know it's been said before, but I think they did such a good job. Alexis Lokai, you just did a wonderful job. If you're 14 years old, wow, wait till we see when you're 18 or 22. You just really did a wonderful job. I want to commend you for that. And your family support is very apparent, and that's really good to have. And Ms. Shelton, also for your heart, and but also for the board, that you're here at the table working with them. You know, taking that as your mission, that's why you exist as a board, and to do that and to do that kind of work. But I'm sure it helps to have these kinds of private support as well. I mean, to have those families stepping up and to be helpful and bring their experience with them. But it's really, really good to see, and just want to commend all of you.
Thank you. Senator Westrom, brief closing comments?
Thank you, Madam Chair. Thank you, Senator Kiffmeyer, Senator Eaton, and Senator Rosen for their comments. I wholeheartedly agree. Alexis is in speech, and so this is just another practice for her. And so you're a great audience for her to perform. I told her not to be nervous, and she did a fantastic job. And so I don't think I have anything more that can add to what Alexis and Darlene and Tony were able to bring this issue to this issue, and why we should pass it and support it. And I would urge your support, and thank you for your attention to this.
Okay, thank you. Then the motion will be, actually, Senator Rosen would like to move the bill. So Senator Rosen moves that.
Yeah. I did steal it from you, didn't I?
Yes, she did steal it, and I'm giving it to her. Senate File 153, as amended, be recommended to pass and placed on general orders. All those in favor say aye. Aye. Opposed? Thank you, Senator Westrom. Next, Senator Gary Dames, Senate File 761. Premium Security Plan, and the motion will be to send it to Finance.
Well, thank you, Madam Chair and members. Today I have Senate File 761. It's the reauthorization of the reinsurance bill. And the changes that have been made from the previous bill we passed in 2017 for 2018 and 19 is in Section 1. We modify the reporting requirements of MCHA with respect to activities of the Minnesota Premium Security Plan. Section 2 delays the transfer of the funds back to, delays the transfer of unused state funds back to the Premium Security Plan until June 30th of 2004. And requires that the MCHA administer the Premium Security Plan through 2022 benefit year. In the reporting, some of the areas that have changed in the reporting is the chairs and ranking members of the committees with jurisdiction over commerce and health make available to a public a quarterly report of the plan of operations, an annual report. The commissioner must do that to the chairs, and all reports must be made public. The annual report must be made available on November 1st of the year following the application of the applicable plan year. The report must include information about reinsurance parameters used, the metal levels affected, the number of claims payments estimated for products offered on the exchange and off exchange, and the estimated reinsurance payments by plan type based on carrier submitted templates. Also, the funds must be appropriated for reinsurance payments and administrative and operational expenses, a report on that, and a report on the total amount of reinsurance payments made to the eligible health carriers. The other section on Section 3, there's a little change there. Minnesota Comprehensive Health Association must administer the Premium Security Plan through 2022, and that's as in the past. So that would be the changes on the reinsurance. And so, Madam Chair, if you would like, we could have the testifiers come up.
Senator Dames, we actually need to move the bill, and I did not do that properly. Could I have someone move Senate File 761, please. Senator Rosen moves Senate File 761. And now to testifiers. I have on my list Bentley Graves, Laura Sales, and Amanda Otero. So, Mr. Graves. Welcome to the committee.
Thank you, Madam Chair. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce, and I appreciate the opportunity to testify today. I want to thank Chair Dames for bringing this legislation forward and building on the 2 years worth of success that we've seen with the state-based reinsurance program. When this bill was first heard in the Senate Commerce Committee, I'd hoped to be joined by a member of ours, who is a small employer, who is a member of the Chamber of Commerce Board, who has 7 employees, who herself is in the individual market and who helps her employees buy coverage in the individual market. She wasn't able to make it that day, but she asked me then, and she asked me again to carry her story kind of through this process in supporting extension of reinsurance, to ensure that folks understand that, yes, the individual market is a place where folks who don't have employer-sponsored coverage goes, but it's also increasingly a place where very small employers are turning to with their employees to find coverage. And she had looked forward to the opportunity to impress upon you all the important role that reinsurance has played in the last 2 years in bringing rates down for herself, in finding coverage for herself and her son, but also improving the options that she has been able to help her employees find for themselves and their families. So I appreciate the work that's gone into this. This program has done exactly what it was hoped would do, which is to bring down rates in the individual market and to stabilize that market. And our hope is that you'll support it going forward to carry it through the rest of the authorization that we've received from the federal government for the next 3 years, so that this program can continue to help folks like Ingrid, our member, and her employees find more affordable options in the individual market. Thanks so much for your time.
Thank you. And now Laura Sales and Amanda Otero.
Senator Benson and members of the committee. My name is Laura Sales, and I'm a lobbyist for the Minnesota Nurses Association. We are a labor union of about 22,000 bedside nurses who live and work all over Minnesota and parts of Iowa and Wisconsin. We are here to testify in opposition to Senate File 761, a bill that would extend the funding for the Minnesota Premium Security Plan. M&A was opposed to the Minnesota Premium Security Plan when it was first passed. In 2017, we asked the legislature to carefully consider if reinsurance was the right approach to address rising premiums and deductibles and shrinking provider networks. The reinsurance program was designed for the state to pay health companies for the high-cost claims, but in return, there was no guarantee the insurance companies would offer affordable premiums, reasonable deductibles, and comprehensive provider networks. The state was proposing to spend around $540 million to prop up a market made up of about 4% of Minnesotans who purchase individual coverage for themselves and their families. We support the intent to help those people, but we would have preferred to do it in a more sustainable way, not this expensive effort to get them into insurance that they might not be able to afford to use. In 2018, the early impacts of the reinsurance program were seen in the 2019 rates for the individual, when the 2019 rates for the individual market were released. In the individual market, rates were slated to decrease, but we wonder whether it's an actual decrease or a smaller increase than anticipated if the reinsurance program were not in place. In addition, according to information on the Department of Commerce website, these were average changes, and the actual rate change that a consumer would experience in 2019 could vary depending on factors like specific plan choice, geographic rating area, and age. And lastly, reinsurance was only one of the factors health plans cited for this average rate decrease. So our objections remain the same in 2019 as they were in 2017. Reinsurance is not a game changer in the broader push to control healthcare spending. Instead, it artificially reduces the cost of premiums. Once the program goes away, there is nothing that will keep the cost of premiums from going up. While reinsurance has shifted the burden of paying the bills to the state government, the program has done nothing to tackle the increasing costs of hospital and physician care or prescription drugs, and it has reduced the federal assistance available to Minnesotans in private plans and to Minnesota Care. So for those reasons, we oppose Senate File 761 and extending the reinsurance program beyond what is already in statute. Thank you.
Thank you. Welcome to the committee.
Thank you. My name is Amanda Otero, and I'm here today on behalf of Take Action Minnesota. We're a grassroots organization representing 55,000 individual Minnesotans in every county in the state and 22 organizational members. We advocate for racial, gender, and economic justice at the local, state, and federal level. I'm here today to raise our concerns about this bill. Alterum's Healthcare Value Hub recently released a survey that found that 47% of Minnesotans struggle to afford high healthcare costs this past year. That's almost half of us who reported struggles including going uninsured, delaying or foregoing care, or going into debt or skipping other bills to pay for care. While I understand that this bill is an attempt to respond to these needs, this is the situation facing Minnesotans now with reinsurance. Reinsurance has given a lot of state dollars directly to plans and has only resulted in lower than they might have been premiums for a very small number of people, most of whom are still in very high deductible plans. Here's what life with reinsurance looks like for some Minnesotans. A 50-year-old couple in Rochester with a 17-year-old child earning $85,000 a year doesn't qualify for a tax credit. They're just over 400% FPL, the cutoff for federal premium tax credits. With reinsurance, the cheapest qualified health plan they can buy with less than an $11,000 deductible is $1,737 per month with a $4,400 deductible. The cheapest plan they can buy, period, is $1,485 per month with a $13,700 deductible. 20% more in premiums might break the bank, but what are the chances it's not already broken for this family? We need to do more than keep the price of their premium this low. This example and countless others like it beg the question, for the amount of relief that we're giving insurance companies, are we getting enough relief for Minnesotans? The premise behind this bill is that we can't afford not to do this. We're wondering if we can afford to do it. Long-term solutions include a Minnesota Care buy-in, but in the short term, we need a solution that makes the health care we've got actually affordable for Minnesotans to use. Thank you.
Thank you. Senator Dames, any further testifiers?
I do not have any.
Thank you. And I have Senator Draheim, Senator Klein.
Thank you, Senator Dames, for bringing this bill forward, and thank you for championing it the last session too. It really helped my district out quite a bit. We have a lot of small business owners, farmers, ranchers that needed this relief. So I wanted to thank you for that, and I think the intent of it, if I remember correctly, was that this was a short-term solution to the rising costs of health insurance. So I don't think anybody intended this to be a permanent solution. So I appreciate you bringing it forward. I just wanted to make that statement in response to the last two testifiers. Thanks.
Thank you.
Thank you. Senator Klein.
Well, thank you, Madam Chair, and Senator Dames. Thank you for bringing the bill forward. And honestly, Madam Chair, thank you for leadership on this issue 2 years ago when I think all of us knew that there was a crisis in premium rates in the individual market. Minnesotans were crying out for solutions, and solutions were hard to come by. And I genuinely want to say that your group and Senator Dames and the chair put in countless hours trying to answer these questions, and answers are not simple. This was the solution that was proposed and passed. I did not support it at the time. I continue to not support it for the reasons that Ms. Sales has articulated, but solutions were needed and leadership is hard, so thank you for the work there. Having said that, it is 2 years on, and we've learned some lessons and gained some wisdom about how this played out, and I think it's worth questioning that, or at least bringing it to the fore as we try to make plans to go forward. So Senator Dames, I have a question about, and if the plans are here, perhaps they're available to help me with this question, about the medical loss ratio in the health plans. So you know, of course, that federal state law requires that the plans must spend 80% of their funds on health care directly. One concern that's been raised is that if they count the claims as part of their health expenses and then later gain reimbursement through the reinsurance program for those claims, are they departing from that medical loss ratio legislation?
I would be unable to answer that, but if Madam Chair, if there's somebody in the audience who would like to respond to that from from one of the companies or from the Commerce Department, but I wouldn't be able to answer that, sir.
Thank you, Senator Dames. If there's anyone who can answer, it's a really technical question that hasn't been addressed in other committees, and so we might need further feedback to the committee. It looks like Ms. Commit is coming forward. The question being, do you calculate your medical loss ratio pre-reimbursement from reinsurance or post? I think that, if I'm summarizing correctly. Ms. Commit.
Madam Chair and members of the committee, my name is Catherine Commit from the Minnesota Council of Health Plans. In response to your question, Senator Klein, I'm afraid I don't know the answer, but I will check on it as soon as possible and get back to you and to the members of the committee. I don't know the answer.
Well, thank you, Madam Chair.
Ms. Commit. And Senator Klein, I have promised you a medical loss ratio report, and I keep forgetting to bring it down, but and I'm sure somebody at MDH who manages that report might be able to give us some guidance, and so we have some homework to do. Senator Klein, further questions from the committee? Senator Klein again.
Madam Chair, I apologize. I have a series of questions, if you'll indulge me. So.
Thank you.
And the second one, I guess, is not so much a question, but a comment just to amplify what the speaker from Take Action reported, that there were individuals under the reinsurance program who actually saw an increase in rates. The Minnesota Department of Health published a graphic on this, so that a family who lived in Moorhead, a family of 4 who had a silver plan and a total income of $70,000, actually saw a consumer increase of $7 per month. A 30-year-old in Detroit Lakes on the bronze plan with a $30,000 income actually saw a consumer cost increase by $15 a month. So the plan, well intended, had holes due to sort of the interaction with min share tax rebates, and so was not perfect in that regard. I don't have a question regarding that, but I just wanted to point out that there were failure spots. But I do have a question, Madam Chair and Senator Dames, about a transfer of funds to out-of-state resources from one particular plan, Medica. In 2017, Medica transferred $120 million from Minnesota to Wisconsin, and since then it has made 2 more transfers totaling $184 million to its out-of-state assets. And again, these are Minnesota taxpayer dollars that are going to a for-profit arm of a nonprofit entity here and leaving the state. I guess, how would you respond to Minnesota taxpayers who feel that that is not a good use of their funds?
Senator Dames, we do have MDH here who is responsible for reviewing those transfers. If you could join us at the table and walk us through the process for Ms. Roderick. Thank you.
To this point, Madam Chair.
Yeah, Senator Hayden.
So, Madam Chair, I was trying to understand, follow Senator Klein's logic of, are we asking the Department of Health to concur that what Senator Klein is saying is correct, because he asked Senator Dames a direct question that it looks like MDH wants to answer, or are we just getting them to clarify that what he said is correct?
Senator Hayden, I was going to ask them to walk through the steps so that the committee has all the same information that Senator Klein is using to formulate his question. And then I think the question then to Senator Dames would be, what do you think of that? But because it is the purview of MDH, which is the purview of this committee, someone who's not on this committee might not know the process. So please proceed.
Yes, Madam Chair and members of the committee, my name is Diane Rydrick, and I'm the Director of the Division of Health Policy at the Minnesota Department of Health. And unfortunately, I don't know that I can answer that question. I think it would be helpful to hear it again. As you were discussing it, we were in the back of the room trying to determine whether this really is something that MDH does, because it's not something that I am familiar with, or whether it's the role of the Department of Commerce. So I think it would be helpful to, if you could walk through it again, we can I can listen a little bit more carefully, and then we can have that conversation, but I don't know that I will be able to answer it right now.
Ms. Roderick, the reason I noted is because you came to me as the Medica transfer was being approved, and that's why I presumed that you would be the correct person to answer it. But please proceed with your question again for Ms. Roderick's benefit.
Sure, and so again, the statement was that I think $184 million in total have been transferred by one of the plans, Medica, to its out-of-state operations, its for-profit operations. And how would you speak to Minnesotans who feel that that was not their intention or their appropriate use of their tax dollars?
And Ms. Roderick, I'm not going to ask you to opine on the appropriateness. If you could just walk us through, MDH did have some role in reviewing those, is my understanding. And then I think the question can go to Senator Deems.
Yeah, Madam Chair, thank you, and Senator Klein. So I was not expecting a question on that today, so I don't have all of my notes here on previous transfers from Medica, but you are correct. Under our authority to regulate health maintenance organizations under Chapter 62D, MDH does have a role in approving certain transfers that they make. And there's been a period of time since 2017 when nonprofit HMOs such as Medica have had the ability to make dividend payments or transfers. There have been 3 over the last 2 years. As I said, I don't have my notes on those transfers here with me. I believe there was one of $55 million, which we just approved a couple months ago, one of $90 million, and one of $30 million. So that would add up to $175 million in transfers. We review those transfers from the perspective of the financial solvency of the HMO, and we look at what sort of payments are required under state law. And with each of those cases, sometimes for different reasons, we've made a determination that they were appropriate. In the most recent transfer, which is the freshest in my memory of the $55 million, it was a transfer from Medica as a nonprofit health maintenance organization to the Medica Holding Company, which is also a nonprofit organization. So I would have to look back at my notes of the earlier 2 transfers that had happened, the $90 million and $30 million to transfer to, make sure that I don't misspeak about the entities that they were transferring to. But for the $55 million transfer that was most recently approved, it was from one nonprofit organization to another nonprofit organization.
Thank you. And Senator Klein, your question to then Senator Deems.
Yeah, I guess I'd still renew my question. Thank you for walking me through the technicalities of the transfers, and nevertheless, I hold the question.
Thank you.
Would you repeat the question?
Sorry, yeah. How would you speak to Minnesotans who felt that that wasn't their intended use of their tax dollars or an appropriate use of their tax dollars?
And I think that's a fair question. Thank you, Senator Klein,
Deems.
Madam Chair. And so my comment would be, first, I don't know why they made the transfers. And for me to make a judgment, I need to know what their accounting system is, why they're transferring, lateral transfers or whatever it might be, why they're doing that before I'd make a judgment if it was a good or a bad thing. The other thing is I'm not so sure we can tie it into the reinsurance, because if I recall, we haven't made the reinsurance payments yet, so I don't see that it would be tied into that. So that would be my thoughts on to this point without doing further research, but thank you for the question.
Okay. Senator Klein, you said you had other questions.
I just one more, Madam Chair, and then thank you for indulging me. I'll move on from the out-of-state.
Madam Chair, to that point, if I could.
Senator Kiffmeyer, yes.
Yeah. One of the things I think that's important to note here is MDH approves those, right?
Senator Kiffmeyer, yes, MDH has to approve
Okay,
them.
so I think some important information might be there as to why did they approve them and what that all into as well. Thank you.
Thank you, Senator Kiffmeyer. And Senator Klein, I'm sorry, Senator Kiffmeyer was to that point, and you had another question.
Thank you, Madam Chair. I do indeed. One of the difficult things with an unexpected phenomenon surrounding the reinsurance bill is the failure of the federal government, through no fault of this legislature, to grant our 1332 waivers so that we were held harmless on our basic health plan. And just some numbers there. In plan year 2018, Minnesota received $130.7 million in federal pass-through funds for the reinsurance bill, and federal funding for Minnesota Care was reduced $90.5 million. Minnesota is expected to receive $84.8 million in federal pass-through funds for plan year 2019 to fund the reinsurance pool, and is projected to lose $77 million in federal funding for the BHP. when we first introduced the reinsurance plan, we linked it to a provision that we would be held harmless through waivers by the federal government for losses to the basic health plan. And Madam Chair, I'd like to offer the A3 amendment.
Senator Klein offers the A3 amendment. Members, it will be distributed. And could we get a page to get the amendment to the author? Senator Dames, do you have a copy of the amendment?
I've got a copy,
I'm going
Madam
to
Chair.
ask Senator Klein to walk us through the provisions of the amendment.
Thank you, Madam Chair. And the amendment is familiar to this legislature from its previous introduction 2 years ago, and simply says that if the waiver request, the 1332 waiver request is not approved, the Minnesota Comprehensive Health Association and its board of directors shall not administer the Minnesota Premium Security Plan past the 2019 benefit year, and the Section 2 will not go into effect.
Senator Dames to the amendment.
Madam Chair, I would treat this as a non-friendly amendment. We have to look back at what started the whole process in the first place, and I hoped we didn't have to get in this, but I guess we might as well. And that is this, before we had the Affordable Care Act, we didn't have a lot of problems. We had some of the best care in the state, health care in the state of Minnesota. So when this plan was put together, the Affordable Care Act, everything was driven to drive the rates up. So what happens is when you come in and you lower the rates, you get penalized because the federal government takes money away from you because you're lowering the rates. And so in this situation here, that's one of the penalties we have because of the fact that the rates were high and we lowered them. And I believe we need to be looking at lowering rates. And so I don't approve this amendment. So I would not, I would say it's a non-friendly amendment.
Thank you, Senator Dames. Further questions to the amendment or comments? Senator Marty.
Madam Chair, I support the amendment, and I think the reality, I mean, when CMS told DHS this, I don't know, a couple months ago that they were cutting the funding for the reinsurance from, what was it, 180 some million to about 84 million. I think it was like a $100 million cut. They gave us no explanation for it. They just pulled the money. I don't know what formulas they use or anything else. And when you look at the cuts they made to the basic health plan, I think we're basically, it has not been a plus. It has not been federal money the way it was promised and so on. And I think that the basic health plan is what we should be focusing on, and we should be focusing on other ways of addressing this. This was a 2-year proposal. As Senator Dames, I think you've said that yourself. It was meant as a temporary fix. And I think we've had 2 years. We should have been looking at other options, but I support this amendment to say we should not continue this thing. It's not saving people money. It's the amount we're getting, how much the premiums come down for how much we're putting into it. We have no way of measuring that.
Thank you. Senator Franzen.
Thank you, Madam Chair. And I guess my comments and questions are general but relevant to the amendment from Senator Klein. And the first question I have for Senator Dames is, can you walk us, through the fiscal note that we just got? It's really confusing to work on an amendment when we just literally got this a few minutes ago.
Yes, Senator Franzen, we did not have it for distribution to the committee, and as soon as I realized we didn't have it, I asked that it be printed. Mr. Albrecht will be walking us through the fiscal note. Commerce got it to us. I think the author received it about 2 o'clock today. So,
Well, Madam Chair, that's fine. I just don't feel comfortable voting for this amendment, even though in theory, looks like I might support it until I understand the finances of the bill in itself, and then have a few questions on that, and then perhaps be able to have the information I need to vote on this amendment.
and if Senator Klein wants to withdraw his amendment, we can address the fiscal note, but we're on the amendment. So do you have questions about the amendment?
Because I can ask my questions, sure.
Yep, the amendment fundamentally changes the fiscal note, yes, in that it would decimate everything past 2019, so you could just assume everything was zero after 2019, but to the amendment.
Well, my general observations and I guess comments is, first of all, starting with recently we just got less money from the federal government for reinsurance purposes to the tune of $99 million than it was expected from CMS. So I have no assurances that we're even going to be able to continue the program that this bill wishes to pursue. I was never supportive of the reinsurance program to begin with. I thought we were rushing into just one proposal, and then now we're rushing back to keep it on for a few more years without really knowing if it's worked, without really knowing the information of how can we rely on the federal government to continue to fund their share of this program. On top of that, today we had a budget forecast, a February forecast, and in that forecast, I was made aware that the Healthcare Access Fund will have a deficit in 2023 of upwards of $919 million, which is very distressing if we're going to be continuing a program that's going to eat up a significant part in growing our deficit in that account. So I think it's certainly relevant that we go through the fiscal note, but more importantly, my message is that I don't believe this is going to be fiscally prudent of us to keep dipping into the Healthcare Access Fund, whether this amendment goes money back to the Basic Health Plan Trust. It's all money that we really don't know where it's coming from, and we're just going to create deficit to be, start deficit spending from this account, and I just can't support that. So if the author wants to comment on the unreliability of the federal government when it relates to one previous withhold of the $99 million I mentioned earlier, and how is this supposed to be funded sustainably when we're actually making it a bigger whole.
Senator Dames.
And thank you, Madam Chair, and Senator Franzen, just let me find something here and I'll answer your questions. Might take me a minute to sort it out through my stuff here. Well, I'll go through with it. I have a sheet here that lays it all out and gives us exactly what where we'll be at next year and the year after and whatever, but let me kind of get a rough idea here. Right now, last year, to start with, we put $542 million into the fund in 2017 for 2018, 2019. There was another, and I'm not sure exactly what it was, how many million it was that came from the Minnesota Comprehensive Health Association went into that fund. And then we had the 130-some million that we received from the federal government on this fund. And the cost for the 2018 year for reinsurance was $138,000 some odd dollars. And that was for reinsurance. So that left a balance of, I don't just remember the exact number, but for the next year now, for 2019, the actuarial estimates are $260 million total for reinsurance, and $84 million will come back from the federal government. The balance at the end of, it shows enough money to go easily through the next 2 years, and depending on what goes on as far as the number of enrollees and stuff, it looks like the money we have now could easily take it through the next 3 years with some money left yet. So we're not asking for new money. We're not asking for a new infusion of money. We are asking to keep the money that's in the pot now, to keep that there and not be returned back. So we're not asking for new dollars.
Senator Franzen.
Madam Chair, in theory, you can say it's not new money, but it's money coming out of the account that hasn't been used up that could be reallocated or just plainly and simple, the reinsurance program end. So you're wanting to add it for another 2 years, eat up the funding there, create a bigger hole in the healthcare access fund, and then what? What comes after that? We're not going to have funding in that healthcare access fund to do another reinsurance program. So that's my point. This experiment seems to be just throwing money at a problem, but not really fixing the ailment or the disease, which is high premium costs in the individual market. We all know that. I'm a small business owner myself. The Mr. Chamber of Commerce's person who was supposed to come up, I mean, I could have given you that testimony. I have to pay individual market for my business, and it hasn't really been cheaper in the last year with reinsurance. The costs are going up. Maybe it's contained at some, but the costs are going up. So can we figure something else, and what is the hurry to start turning on this reinsurance program when we have no end in sight of how we're going to fix the problem? So Senator Dames, I just don't think this bill is actually going to solve the problem you're seeking to end, which is increasing price in the individual market. And the fact of the matter is that our state budget today has shown, or forecast that has shown that the economy is going to slow down. We're not going to have all this influx of money, and the money that we have there today, it'd be prudent just to leave it there and figure out a long-term solution. Thank you, Madam Chair.
Madam Chair.
Senator Dames.
And Senator Franzen, thank you for the question. I do want to give you the numbers that I was looking for. At the end of fiscal year 23, it's estimated that we'll still have $350,534,000 in the fund. So giving you those numbers, when we talk about why it's important to do this. Now, I understand that when we have these programs that we reduce the amount of money we get from the federal government for our BHP, basic health plan, I understand that. But are we here today to figure out ways to reduce the cost of insurance to the individual market? Or are we here today to figure out how to build a BHP plan up by not reducing rates? Myself, I'm going to stick up for my constituents and try to reduce the rates. So now we need to look at what the other options are. So let's look at some of the other options. Let's start with the 20% rebate option. If we take a look at the cost of reinsurance for 2020 per individual, it's going to be about $534. If we take a look at the rebate of 20%, it's $1,539 average. Now, not only have we got over $1,000 differential there, but if we take a look at the reinsurance, it's covering approximately 160,000 people. If we take a look at the rebate, it's going to cover much less than that. Then the next step we have is when we start taking a look at the increased cost of health insurance because the reinsurance goes away. There's estimates of anywhere from 50 to 54%. So let's say it's 50%, and we give a 20% rebate. Now we have the people out there paying 30% more than they would be under reinsurance, which would be considerably cheaper. Then we look at another piece of the puzzle when we start talking about having tax credits. The tax credits wouldn't start until 2021 under the governor's budget. And these numbers, by the way, are numbers that's been taken out of the, taken pretty much out of the governor's budget and out of today's forecast that I'm giving you. So now we take a look at the tax credits. They're not to come into play until 2021. We look at OneCare, and that doesn't come into play until 2023. So when you ask me why am I moving this forward and why am I trying to get this done, is because I'm working for my consumers and I want to keep the costs down. Now, if somebody else wants to come up with a different program that can do this, that's one thing, but we're not seeing it. And let me finish, please. We're having a real hard time getting facts and numbers from anybody on these other programs. So that's why I'm doing it.
Madam Chair
Senator
and
Benson.
Senator Dames, I'm not questioning your motives of why you're doing it. I got plenty of emails from my constituents in Senate District 49 that are in the individual market because most of them are small businesses, solo practitioners, and they're entrepreneurs and doing great, but they're getting the shaft when it comes to our insurance market, and they're paying a lot of money into it. So I get the need for it, and I applaud your efforts. The other piece, and a big elephant in the room, is provider tax. That's going to go away. That's going to bring in less money to do reinsurance and to, frankly, to do anything we want, basic health plan, you name it. So to do reinsurance without taking looking at the bigger picture, I mean, I don't know whatever the governor has in his proposal, those are great. We're going to discuss them, but we have an issue today, which is we're going to have money that's not going to come in with the provider tax sunsetting in 2019. So you're actually spending more in this account where we're going to actually have less money to begin with. So if we're going to do something and it's reinsurance and we're going to come here 2 years later and trying to turn it back on, I just don't see it being sustainable or helping our constituents long term. So I think this is just short-sighted. It might help today, but tomorrow we're going to feel the pain, and we're going to have to scramble to figure out how we're going to pay for it. So I just don't think it's good policy, good fiscal policy, but we have the same intent to fix this issue, and just not by reinsurance, by throwing money at a problem and not really fixing it. Thank you.
Thank you.
Thank you. And to the list, let me see. So I have Senator Jensen, were you to the amendment or to the underlying bill? Okay, because we are to the amendment, and then there'll be plenty of time for the rest of the bill. Senator Jensen.
Thank you, Madam Chair. And thank you, Senator Dames, for bringing this bill to us. In regards to the amendment, I certainly understand what Senator Klein is getting at. I think that in terms of not being held harmless as we'd hoped we wouldn't, I think that we don't really have the luxury of really constructing something in time to move in that direction. Senator Dames has been quoted on record as indicating that he doesn't think that reinsurance is necessary, the do-all, end-all, cure-all. But this is something that we can put in place. And if you look at the numbers that we have at $542 million, this actually cost us somewhere around $85 million for 18 and 19. So we are sustainable for the next 3 years, and we already have the waiver. And we don't have to have another waiver. Senator Klein's amendment is asking us to get another waiver, and that waiver would totally hold us harmless so that we would retrieve those dollars that we didn't get. And I think that we're entitled to them, and I would agree with Senator Klein, but I don't think we have the luxury of being able to wind that out. One of the things that concerns me is pre-existing conditions. This bill, going forward, provides absolute protection for people with pre-existing conditions. And I think that's one of the reasons why Senator Dames is extremely motivated to see this bill be the one, because folks with pre-existing conditions have been dangling out there long enough. They don't need to think that we're working, trying to find some solution. We have a solution that will take care of pre-existing conditions. This is a bridge. It's not a permanent solution. But I think it is indeed a bridge to making certain that people with pre-existing conditions are protected. It's not an experiment. Someone mentioned an experiment. We had MCHA experience for more than 30 years. And we had the 2% sales tax since 1992. I think it's important to realize that for reinsurance, the dollars are not coming from the 2% tax. Right now, the Healthcare Access Fund spending is 46 to 50% devoted to MA spending. In regards to the BHP, we're getting 90% of that coming back to us through the feds. So while this might not be the perfect place to be at, and I'd be disappointed if I thought that our efforts were going to stop here, I think this is just, we've got business to do. We've got to get the work done. This isn't my favorite solution, but I think Senator Dames is looking at the view from 30,000 feet and saying, you know what? We got to continue to support the individual market. We can't let the individual market's problems bleed into the small employer fully funded market, and that's what could happen. So I have to speak against the amendment because I don't think that that's going to get us where we want to go, and it's going to put those folks out there with pre-existing conditions at risk. And I don't think that's where we want to go. Thank you, Madam Chair.
Thank you. After Senator Jensen, Senator Marty, were you to the amendment or to the underlying bill? Okay, and Senator Wickland to the amendment.
Thank you, Madam Chair. Yes, I wanted to speak in support of the amendment, and my support comes from reading in the fiscal note, starting on page 10. It talks about this, the situation that we're in. The 1332 waiver for the premium security plan was only partially approved by CMS, and Minnesota Care would experience reduced federal BHP revenue due to the reduction in individual market premiums. And it reflects, this fiscal note reflects the projected reduction in federal BHP funding, which would need to be replaced with state funding. If you go to page 11, it actually has a table of the reductions over each year, fiscal year 2020 through 2023. This reduction is going to have an impact on our general fund, so I think it is appropriate for us to have discussions about whether this solution is the best solution or if there's alternatives. Getting to the amendment, what the amendment would seek to do is to remedy this by getting assurance from the federal government that we would receive the funding from the state or for the state's basic health plan. So I'm in support of the amendment. I think it goes to address that issue that is talked about on page 10 and 11. And I think, having the fiscal note at the last minute, it's hard to digest all of it, but I mean, what I see here, this is a significant impact on our state. It can be a significant impact on our general fund over time. So I think this amendment seeks to address that, so I support it.
Thank you, Senator Wickland. Senator Hayden, to the amendment.
Well, thank you, Madam Chair. To the amendment, I guess I would agree with my very fast reader over there, Senator Wickland, who's digesting the fiscal note in record amount of time. Thank you. I'm glad for your intellect. And Senator Dames, I agree with Senator Klein. We should support this. The landscape in the way that we talk about this, it kind of changes from year to year. So when we started this conversation, it was all predicated on us getting this waiver and us getting the money back. And now we're like, oh, okay, well, we're not getting it back, but we still need to do it. Well, what Senator Klein is attempting to do is to get us refocused, get us reframed. I think that's what my wife told me, the new languages, and all my business friends could say. Let's reframe back to what we were originally trying to do, which was to get to a point in which we said the argument that we made is like deja vu, Senator Daines. I think I was right here and you were right there. The argument that we were making was that we were going to get reimbursed, and then we didn't. This essentially is robbing Peter to pay Paul. We're getting less money in another account for a certain subset of people to help another group and another set of people. So we are picking and choosing here because the people in the BHP are suffering. Senator Daines, in all of this, I do have a question for you. Do you believe that we should repeal the sunset of the provider tax?
Thank you, Senator Hayden. Madam Chair, thank you, Senator Hayden. You asked me the question in Commerce, and I stated at that point in time that I didn't think that was totally linked to this, and so I wasn't going to get into that discussion. My answer is the same today.
Right. Well, Madam Chair, and Senator Daines, you're right. You knew I was going to ask it, and I knew I was going to ask it in this committee, because in this committee I knew that we would have the expertise in the room to make the linkage. So the linkage is there. If we decide if we're going to be in denial about it or not, the linkage is there. I think that members on both sides of the aisles have made the linkage to provider tax, reinsurance, BHP, 1332 waivers. They're all alike. This is the problem with this place, is that we talk about this in silos. We reframe the discussion to make it work for us, and it's not working. Senator Franzen laid that out pretty clearly, that this isn't going to work. She laid out what the forecast said about the provider tax. We won't, or you don't want to answer the question about how do you feel about the provider tax, which is the main funding source as we go on for this program. And to Senator Jensen's point, we've been at this for a long time. We keep on getting ourselves in this situation where we got to do it right now. Well, Senator Jensen, you've done phenomenal work in the interim. I've been on some of these work groups. We've had a long time to talk about this issue and to figure out where we're going or where we're not. So, Madam Chair, I guess I'm getting to some of my closing comments, so I do want to get back to the amendment. I think the amendment is poignant and important because it creates the pressure around here that we need in order to say that we got to get our work done. Right? We got to figure it out. If this is about pre-existing conditions, which I'm not sure one way or the other, and that argument is shifted to, Senator Jensen, you weren't here when we argued the ACA, so I won't hold you to that, but there was a lot of your colleagues here that this pre-existing condition wasn't seeming to be the issue. But I digress with that issue. I think that this is reasonable, it's important, and Senator Dames, I think it holds us to make sure that we get our work done and we don't run into a situation much like I did when I was in college where I procrastinated to write my papers at the end of the term each and every year. And that's what it seems like we're getting in the habit of doing. So with that being said, I think that we owe it to our folks in Minnesota to support this amendment.
Thank you. Any further questions to the amendment? Senator Nelson to the amendment.
Thank you, Madam Chair. I speak against this amendment. I'm concerned about the increase in premium. If this amendment were to go forward, I understood, and maybe Senator Dames, you can acknowledge this, that without the reinsurance program, that insurance rates would go up by over 50%. And I just want to clarify if I understood your comments correctly.
Madam Chair?
Senator Dames.
Senator Nelson, that is correct.
Madam Chair.
Senator Nelson.
This is devastating. Excuse me.
Senator Hayden. As soon as Senator Nelson's done, I'll let you speak to that point.
Okay, I just wanted to make sure we got to that point.
Thank you, to that point.
Yeah.
Thank you.
It's customary for us to do that sometimes, Senator Nelson.
Thank you. Thank you. So my concern is that we're going to see insurance rates skyrocket by 50% on the private market. Those are the small businesses, those are the farmers, those are the people who are already paying out of pocket, some up to $40,000 a year for coverage and deductibles. And to think that we would increase that by over 50%, I think is a very frightening proposition. Now, if people think that we don't need private health insurance anymore and we just need to go to government paid health care, maybe that's okay. But I think this would decimate the private insurance market. It would be the end of entrepreneurs, small businesses, sole proprietors, farmers. So I share Senator Klein's concern with where we're finding ourselves today, and I will save those comments to the bill itself. But this amendment will totally decimate our private market, our farmers, small business. I think it's just a very dangerous amendment. Obviously, I'll be voting no.
Okay. Senator Draheim.
So, Madam.
Oh, I apologize, Senator Hayden. You reminded me.
Good, and I'm sorry for cutting off. I just wanted to, this number of 50% has been flying around. I don't know where Senator Dames got it. I suggest that he got it from a reputable site because he's saying it. Senator Nelson is following up. So, Senator Dames, where did that number come from, 50%?
Thank you, Madam Chair. And Senator Hayden, that number comes from the Kaiser Corporation, Kaiser comparison on selected health plan premiums. And that was just recently done, and that's where it's coming from.
Senator Hayden, thank you. Senator Eaton, are you to that point?
To that point, Madam Chair.
Thank you, Senator Eaton.
Senator Dames, so what you're saying is the insurance industry says they're going to raise the rates 50% if we don't give them millions of state dollars.
That's one way of
Senator
putting it.
James.
I would, thank you, Madam Chair. I would not put it that way. It seems to be we have two schools of thought around here. One school of thought is if we give private industry any money, we're just throwing money at them and we're giving the insurance, these big insurance companies all this money. We need to understand and remember that these big insurance companies are regulated by our Commerce Department. And with those regulations, we're not just going to give them $139 million and not expect that to be regulated. It is highly regulated. The money that was given to the reinsurance drives the premiums down, just like reinsurance works in any other area of insurance. It drives the premiums down to the consumer, and that's where these dollars went. And this report shows that they could go as high as 50% increase. There's other reports I've seen, it's at 54, and that could happen, yes.
Madam Chair.
Senator Eaton.
Thank you. Senator Dames, I guess I'm just wondering, I haven't seen any data that shows where this money goes and how it's decreasing these rates. All I'm hearing is the insurance company's word for it.
Senator Dames.
Thank you, Madam Chair, and Senator Eaton. I'm sure there's a lot of access that you would have if you want to pursue that. I'm sure you can go to the Commerce Department and you should be able to find out from them how their claims are spent, and that should be available.
Senator Draheim, to the amendment.
Thank you. Real quick, I found this article that was out today from Congressman Angie Craig, who represents part of my district. It says, author bill to help states reduce health care premiums. State Health Care Premium Reduction Act aims to lower health care insurance premiums in the individual market. And then in the bottom, it references reinsurance. So just pointing information to this amendment. Thank you.
Thank you. Further questions to the amendment? Senator Klein.
Madam Chair, I have closing comments to the amendment if nobody else has any.
I do have one question for you, Senator Klein. On page 1, line 15, do you intend that if this amendment goes on, then rates that are to begin being worked on this spring and filed in July and August would be impacted by this amendment?
Madam Chair, can you repeat the question, please?
So, Senator Klein, on page 1, line 13, said that if we don't receive the waiver, then we couldn't do anything past the plans that are in existence for this year. And the waiver takes Commerce time to request, and then it takes federal time. It took us till October last time, and that means the rates that would be eligible to be filed for the 2020 plan year would not, if this amendment goes on and is carried forward, would not be eligible for any reinsurance consideration as they developed their rates, because we probably wouldn't get the waiver until after the rates were final filed. And so I'm wondering if that's your intention, Senator Klein.
Madam Chair, I'd be glad to discuss that with you further to perfect the amendment, but at this time, that is an accurate reading of what the amendment states.
Thank you. Then I will oppose the amendment as well. Thank you, Senator Dames. Senator Jensen.
Thank you, Madam Chair. And I would just point out that I think part of the reason that the Democrats in the House and Representative Lori Halverson, why they've pushed this forward and passed it already through one committee, is that they're sharing the same concerns about the timing that I think Senator Benson raises. In terms of setting insurance rates, I just don't think we have the luxury that if we go through this process as the amendment calls for to get a waiver that would fully hold us harmless. I just don't see it as a realistic option. I absolutely share my colleagues on the other side of the aisle concerns about the fact that we need to be creative as we go forward and look at this, because I would certainly hope that this isn't our best effort in solving this problem. But in terms of bridging us now to getting done what needs to get done this year, I think the bill in front of us does that. So I speak against the amendment, I speak for the bill, but I certainly do appreciate the urging on the part of my colleagues to let's not let this go. We need to keep pushing forward, as Senator Hayden said.
And Senator Klein, closing comments to your amendment, please. Oh. Okay, so Senator Hayden, did you have a question?
Madam Chair, I would like to ask for a roll call.
I'm sorry.
I'd like to ask for a roll call on the amendment.
A roll call has been requested. A roll call will be granted. Senator Klein, closing comments.
Well, thank you very much. And just to respond to some of the questions that were made, and they were all very thoughtful. And by the way, I want to recognize the tremendous amount of work that goes into this difficult work by Senator Dames and by you, Madam Chair, and by Senator Jensen. And we've talked offline, and I know that you're earnest about trying to provide health care to Minnesotans. Senator Draheim referenced that Angie Craig has supported a federal reinsurance program, which would not rely, of course, on a waiver, so wouldn't really be relevant to the amendment as I've offered it, where we do depend very significantly on these waivers to sustain our health care funding here in the state. Senator Nelson seems to misunderstand the amendment, suggesting that I'm shutting down reinsurance altogether, which could lead to possibly 50% rate hikes. I'm simply trying to protect Minnesotans who are losing dollar for dollar by basic health plan coverage from the federal government. But mostly I want to echo what Senator Hayden said about this. The reason I think a roll call is important on this is because this is a very different federal reinsurance understanding bill than from what we had 2 years ago, where there was an assumption that these 1332 waivers would go through and our state would be held harmless for hundreds of millions of dollars in basic health plan funding from the federal government. It now seems to be the assumption, as stated by the author, that we are not going to assume we'll get these waivers, that we'll continue to lose $1 in for $1 out here in the state as we implement reinsurance and lose those dollars to the basic health plan. So if that's the solution to holding down rates in the individual market going forward the next 2 years, that's a different solution than what we voted on 2 years ago. So I do call for a roll call. Thank you.
Senator Nelson, we're going to a vote very quickly.
Oh, yes, just one comment. I do believe I do understand the amendment, and I was very disappointed that we did not get the 1532 waiver. But my comments were based upon line 1.12 and 1.13, which stated if we did not get the waiver, that the reinsurance plan would not continue, which is what the amendment states.
Members, we are going to a vote. The clerk will call the roll.
Chair Benson?
No.
Senator Jensen?
No.
Senator Marty?
Aye.
Senator Abler? Senator Draheim?
No.
Senator Eaton?
Yes.
Senator Franzen?
Yes.
Senator Hayden?
Aye.
Senator Kiffmeyer?
No.
Senator Klein?
Yes.
Senator Matthews?
No.
Senator Nelson?
No.
Senator Rosen?
No.
Senator Wickland?
With a vote of 6 yes and 7 no, the amendment is not adopted. To the underlying bill, Senator Marty.
Madam Chair, first I want to go back to something that I think Senator Kiffmeyer responded to related to Senator Klein's comments about the Medica transfers. I think the real history was $30 million went to a Wisconsin subsidiary, which since much of this was public money, and I think I see nonprofits as holding a public asset. $30 million went to Wisconsin, which I don't see how that's in our interest. Then the next $90 million went to a for-profit subsidiary, and the last 55 that the department was commenting on, I'm not sure where that went, but I believe it was in Minnesota. But we do have a bill, I dropped in a bill that would restore the old law so they could not make those transfers. And the Department of Health, Senator Kiffmeyer, you were saying they did approve these, and I had a big fight with the department on it in all these cases because I argued they do have the authority to stop them. They said, no, we don't, because their lawyer's interpretation of the law was that they could only interfere if it was all or a substantial portion. I argued $90 million was a substantial portion, and we had a disagreement, but they felt they had no choice under the law we had. So I think we should repeal that law. We should go backward on where we were so that these nonprofit assets remain nonprofit assets. On the bill itself, again, this was set up a couple years ago as a temporary fix. I think a lot of us didn't support it at that time. It's very expensive. I still question the numbers here. This, according to the fiscal note, this bill brought down premiums by, the subsidy brought down premiums by 17.5 points. We're now told we get rid of the premium, they'll go up by 50%. I mean, those are the numbers we're working on. I just don't think these are real numbers and a good way to do it. I think there are better ways to address the problem. And again, I don't think our goal should be fixing the small insurance market. I think ours should be getting health care to people, not health insurance. So I oppose the bill, and I understand, Senator Dames, you're trying to do something that you think will help, but I think the amount of money we're putting into this and what we're getting out of it, well, in one case, well, we're saving 17% and we cancel it, and now we're going to spend 50% more. I just don't buy it.
Thank you. And members, we do have a fiscal note. I'm going to ask Mr. Albrecht to give us brief highlights on that fiscal note. We are going to send this bill to the Finance Committee, and I will let you know that I have some concerns about the fiscal note. Just the MNsure portion, I compared to the fiscal note when this bill was originally passed. Their underlying base assumptions have foundationally changed. There's a significant amount of work to do on this fiscal note, but should Senator Dames prevail in this committee, it will be reviewed before Finance. So, Mr. Albrecht, to the fiscal note.
Madam Chair and members, I think the easiest way to work through this fiscal note is to go past the first 3 pages, which summarize the last 12. And so on page 4 is where the fiscal note for the Department of Commerce begins. And if you turn to page 5, in the middle of the page is where the expenditures are addressed. And the assumption here is that in fiscal year 2022 is when the payment for plan year 2020 would be made, which is the first plan year under the bill that there's a new payment. And it is showing that there would be $84.1 million of state funds paid in that fiscal year, and the same principle is working in fiscal year 2023, which represents the amount of the state share of $100.9 million, reflecting the 2021 plan year payment. You can also see the amount that the Department of Commerce is assuming, the $84.758 million of federal money. They are just assuming that the amount that is paid in 2019 continues into the subsequent plan years. Also, if you go to page 7, near the top, there's a table that shows you for fiscal years 20 through 23, sort of the revenue and the expenditures in the fund. The next to the bottom line line that says MSHA expenditures, that reflects the total amount of reinsurance payments by fiscal year, which again is not the plan year. And then the very bottom line tracks the balance by fiscal year, and that's where the $350.5 million number that Senator Dames mentioned came from. On the same page, Madam Chair, under the long-term fiscal considerations is fiscal year 2024, which is beyond the budget horizon that we're currently working in. And that little table there reflects the plan year 2022 payment and shows that when all 5 years of reinsurance are settled, the projected balance in the reinsurance fund would be $231 million. And that's the projected amount that would then, in fiscal year '24, be returned to the Healthcare Access Fund. And that is a summary of the Department of Commerce portion of the fiscal note. Beginning on page 9 is the Department of Human Services portion. I think the best way to explain this one is, I guess, to start with on page 11 under the expenditure and revenue formula, because this bill would lead to reductions in premiums for all 4 years, or I guess 3 years. And because the federal revenue for the basic health plan is based on the premium, there's additional revenue loss in the basic health plan. The result of that in this bill and in this fiscal note is an interaction with the Healthcare Access Fund. So once the balance in the basic health plan account is reduced to zero, the expenditures for Minnesota Care begin to shift to the Healthcare Access Fund. There's also an interaction based on the November forecast between the Healthcare Access Fund and the general fund. There's, in current law, a transfer to the general fund that depends on there being a balance in the Healthcare Access Fund. So when the BHP revenue is reduced, the first thing that's going to happen under this bill is that whatever balance is in the Healthcare Access Fund, which is about $48 million, as of the November forecast in fiscal year 21, the first thing it's going to do is spend that money and then start to reduce the statutory transfer of $122 million that goes to the general fund. That's why there's a $79 million expenditure in the general fund. And then in 2022 and 23 in the November forecast, because the balance has already gone negative in the Healthcare Access Fund for those fiscal years, the transfer is not an issue. So the entire reduction in the cost, or in the revenue to the basic health plan, turns into a cost for Minnesota Care in the Healthcare Access Fund, and that is the $101.7 million in 2022 and the $54.6 million in 2023. And that is summarized in the table on page 11 in the middle of the page that shows all of those numbers and the net fiscal impact by year. That's the shortest summary I could come up with for the DHS part. For MNsure, putting aside Senator Benson's questions about the premium assumptions, and those are fundamental to projecting what MNsure is saying here. But what MNsure is saying here is that their revenue depends on the amount of premiums, and that the actions that have been taken to date have reduced their budget to, I would characterize it as what they say is the minimum amount of money that they need to run the MNsure exchange. And so they're saying that if their revenue decreases any more than their current revenue, then they're assuming that they need at least their current budget or their current projected budget, and assuming that the general fund would pick up that amount. So those amounts of $2.4 million in 21, 4.9, you can see them there. They're just assuming that the general fund would need to pick up the revenue necessary for them to continue operating the exchange at the current level.
Okay, members, the day your algebra teacher told you were going to need algebra and you thought, ha, today's the day. So this is a really complicated fiscal note. It does need some work. I will tell you, when I pulled the fiscal note from the first time we passed this bill, they were showing adjusted average premiums of $371.93, and the ones they're calculating off of here are $470. So we have a mismatch of information that I do need to have clarified, but I will have members look over the fiscal note, ask the questions we can come to now, and then continue this work as we hopefully move this bill forward. So questions to the fiscal note, members? Senator Eaton.
Thank you, Madam Chair. My concerns with the fiscal note are all the assumptions. We started out with this program, it was going to be temporary, and now we're looking at a 5-year plan for it. And we assumed when we started that we were going to get $183 million from the federal government. We got 84. How can we assume in this fiscal note that we're going to continue to get 84 every year when our assumption from last year was so wrong, like by half and more? So I have a real concern with that. I think that this is really irresponsible to do this. The points where my understanding of where we're going to be dipping into the general fund pretty much coincided with the forecasted deficit in the general fund. So that's not going to work so well. So yeah, I have some real concerns about this fiscal note and this program in general.
Thank you. Members, to the fiscal note? Questions, concerns? I know you haven't had much time to look at it, but there will be a robust debate, I'm sure, in finance. Senator Hayden.
Good. Well, thank you, Madam Chair. And I'm a new finance member, so we're going to have a chance to go over it here. But what I will say is it is complicated. It does have interaction all the way through most of the programs that we offer. And so with that being said, I want to make sure that, especially as I talk to Senator Dames, that your bill does, Senator Dames, do a lot, regardless to where you stand on it. Even if Senator Draheim, we get our good Congress woman there to help us out in Washington, which I think would be fantastic if she can get federal funds. But whatever it is, it has an interaction in play, regardless of what we believe what they're saying is right. If there's a gap between the assumptions of 3 or 4 years ago to now, well, there was a gap between what we thought we were going to get back and what we're actually getting. I just want to make sure that this committee in particular and this legislature, as Madam Chair, you're doing I think in a very good way, but we actually are having this conversation, that we are actually taking our time to understand what we're doing, to understand what these fiscal notes are saying, to look at this. If we talk about bending the cost curve and doing all the stuff, we can't do any of it if we're just if we're just kind of taking little pieces of this puzzle and kind of pushing it through. I think we really need to take a step back. I mean, this bill is clearly going to continue on a journey, but I think that we need to take back. And frankly, our friends in the House that someone invoked, there isn't clarity over there. There may be a chair or two or a few members. There's a whole bunch of members over there on both sides of the aisle that are telling me that they have the same kind of questions. So I just want to make sure that this fiscal note, as it reflects to the BHP, as it reflects to interactions with the general fund and transfers out for MA, and now the underlying budget for MNsure, I think we really need to take our time to make sure that we don't have consequences. It would be unintended if we didn't think they were happening. These are real consequences that could happen if this plays out the way it looks.
Thank you, members. Anything else to the fiscal note? Okay, Senator Dames, to your bill, closing comments.
Thank you, Madam
I'm
Chair.
sorry. We are 15 minutes past our time. Any closing comments from members? I'm going to ask that we keep them very tight. I know Senator Dames will. So closing comments from the committee briefly. And Senator Kiffmeyer, you are first on my list. Thank you. Senator Nelson.
Oh, thank you, Chair Benson. I'll just be very brief. We have talked about all the difficulties that we have here and the assumptions that we might not have the most confidence in. But I would say that, we did talk about this as a Band-Aid. It was a Band-Aid, and I would even admit that it's an expensive Band-Aid. But the issue is we were left with fixing a federal flaw, really, from 2010 that literally destroyed our individual market. I don't know that that was the intention, but that was the outcome. And so we're left once again here at the state needing to pick up the pieces from what the feds have left us. And so my understanding is that we are not allocating additional dollars to this reinsurance plan, but that it worked so well or better than anticipated so that there is still money left in that account. And I understand, Senator Dames, that your bill is to simply extend the time frame with which those dollars can be used to continue to hold down premiums. So we are not going to solve the whole issue here today, but I definitely am in favor of extending the timeline so that the dollars that we have already allocated to help hold down premiums can continue to do so.
Thank you. Further comments? Senator Franzen.
Thank you, Madam Chair. And I'll try to be brief. I'm not opposed to reinsurance. I actually had a bill on reinsurance when Senator Daines' bill came up. It never got a hearing, so that's why I'm a little bit disgruntled because after 2 years, we haven't made any adjustments. We haven't learned. We haven't made any changes, and we're coming just to flip it on and extend it without really delving into the details, which is what our committee should be doing, really understanding this fiscal note, really understanding the dynamics with the other bigger decisions that we're going to have to make as a committee, like the provider tax and other transfers that are coming or may not come from the federal government. It's so unstable up there. I want to dismiss or characterize it a little differently. Reinsurance was part of the bigger picture of ACA. It just didn't get put in and didn't get funded. So we were looking, the bill I had back in 2017 was modeled after Alaska. Some states are doing it, but there's only 8 states that have done this. So it's still an experiment to a certain degree. And I'm not saying we shouldn't do it and it's not going to work, but there's really, in my opinion, no skin in the game, no learnings or adjustments to this bill. It's just extending it without being thoughtful of how we can figure this bigger picture of how we're going to fund this. And to be simplified, reinsurance is just insurance for the insurance companies. So I would like to be able to figure out from their learnings, how can we make this better so it works to really drop the cost and lower the cost of premiums at the individual market level, because it's still a problem. And I don't think this is the end of this issue and just flipping it on. I think it's, frankly, we can do better than just extending something. We can learn and we can make adjustments. And I would like to see that in the final bill. Thank you, Madam Chair.
Thank you, Senator
And
Jensen.
we'll ask for a roll call.
Thank you, Senator Jensen.
Thank you, Madam Chair, and thank you again, Senator Dames, and thank you, Senator Francis. I did want to just piggyback on top of your comments. I also had concerns about, is there a way we could do this better? And I went back to 2017 and 18, and I looked at my notes, and I looked at what Senator Benson and Senator Dames and some of the members of the House had looked at, where they were looking at where to set the attachment point, what percentage to use, where do we put the cap on, and things like that. And I did go over this within the last 48 hours with Senator Dames as well. And they have been looking at this to see if there was a way that we could readily improve it in light of the time constraints with the existing waiver we already have. So I have the same concerns you have. I'm confident that Senator Dames and his staff has done their homework.
Thank you. A roll call has been requested. A roll call will be granted. Senator Dames, closing comments.
Thank you, Senator Benson, Ms. Chairwoman, and members. I just want to, for the record, just state that this is the bill that the House has. Representative Lori Halverson's carrying it over there. She's a chief author. She had several co-authors, and I'm carrying her bill over here. So thank you, members and Madam Chair, for having this discussion today.
Thank you, Senator Dames. Senator Rosen renews her motion that Senate File 761 be recommended to pass and sent to the Committee on Finance. The clerk will call the roll.
Chair Benson.
Aye.
Senator Jensen. Senator Marty.
No.
Senator Abler. Senator Draheim.
Aye.
Senator Eaton.
No.
Senator Franzen. Senator Hayden. Senator Kiffmeyer.
Yes.
Senator Klein.
No.
Senator Matthews.
Yes.
Senator Nelson.
Yes.
Senator Rosen.
Yes.
Senator Wickland.
A vote of 7 ayes and 6 noes means Senate File 761 has passed. Thank you, Senator Dames. You're going to Finance. Members, we do have one more bill left, and as a courtesy to Senator Wickland, I do want to get this done even though we're past time. Senator Wickland, to Senate File 875. I know she has worked on this extensively. If you could present your bill, Senator Wickland. To the testifiers, I know you have been extremely patient. That bill did go longer than we planned. We are not going to be able to have everyone testify. Senator Wickland will present her bill. We will take 1 for and 1 against. We're going to have an author testifier, and then we will proceed through our list. I'm going to ask you to keep your statements to 30 seconds and be very succinct. Senator Wickland, and we do have members who have to leave at 5 o'clock if we want to pass this bill.
Okay.
Senator Wickland.
Thank you, Madam Chair.
Senate File 875.
Thank you, Madam Chair. I'd like to move Senate File 875, which is a bill to establish a registry for spoken language healthcare interpreters. This bill seeks to improve health equity and health outcomes in Minnesota for limited English proficiency patients. The bill has bipartisan support and is the result of the efforts of many people. It's unfortunate we won't get to all the testimony, but I do think that reflects that there are a lot of supporters and there are some who have concerns still. We have focused on meeting the needs of patients and improving patient safety, as well as creating a system that acknowledges the passion and dedication of interpreters working in Minnesota. I'm going to try to skip over some of my testimony so that I can get to the other testifiers. The bill has been done with work over the past several years. The outline of the bill is very similar to that of a couple years ago that you have heard in this committee. To promote quality healthcare interpreting, the bill would implement a registry system which will have 3 levels representing increasing qualifications. The core level interpreter would need to demonstrate knowledge of interpreting ethics and standards of practice and demonstrate knowledge of basic medical terminology, either by taking an exam or by taking a 40-hour course in medical interpreting. The second level, interpreters must demonstrate oral proficiency in English and a non-English target language. And the third level is a certified interpreter, and they must pass certification exams. Other aspects of the bill includes establishment of an advisory council to provide expertise and guidance to the Department of Health. That's on page 10 of the bill. It establishes a complaint and discipline process. Today, there's no process to report complaints and no process to investigate allegations. The healthcare interpreters must be listed on the roster today to receive reimbursement for their services from medical assistance in Minnesota Care. This bill would continue that requirement. They must be on the registry if they are going to receive reimbursement for their services from public programs. If they are not receiving reimbursement, they do not need to be on the registry or roster. Let's see, I think those are the highlights of the bill. You have a summary that includes, and I do have an amendment. I'm just realizing that I didn't move that. I have an author's amendment that I'd like to move.
Senator.
The bill summary reflects the amendment.
Senator Wickland moves the A3 as an author's amendment. All those in favor say aye.
Aye.
Opposed? Thank you, Senator Wickland. And members, I'm going to have you note on page 13, the appropriations are blank. We do not have a fiscal note, so this is going to make its path through the policy committees. And when we have a fiscal note, we'll be able to bring it back here. So Senator Wickland, please proceed.
Thank you, Madam Chair. I'd like now to have the testifiers begin because they will be able to speak more about the outreach and the work that's been done in creating this bill that you see before you today. So first, I guess I'd like to have Angelique Cameron.
And Ms. Cameron, to the extent you can be very brief, we'll get more testifiers in. Welcome to the committee.
Right. Thank you, Madam Chair and members of the committee. For the record, my name is Angelique Cameron, and I am Research Director at the Council on Asian Pacific Minnesotans. I'm joined by my colleague here from the Latino Council. As staff to the Council on Asian Pacific Minnesotans and Minnesota Council on Latino Affairs, we are here to urge you in support of Senator Wickland's bill. The state ethnic councils were established by you, the legislature, to advise you on behalf of our respective constituencies of over 500,000 Minnesotans. Of that, 157,000 of them are limited English proficient. Given the extent of language barriers that exist to impede healthcare access for our communities, it became apparent to our agencies that work needs to be done to create standardized minimum levels of training for interpreter services for limited English proficient patients in Minnesota. So I'll just briefly say that this bill addresses some major concerns that we have heard from Minnesota's LEP community. I won't go into the details, but the major points are healthcare access for LEP communities, patient safety and the reduction of medical errors, specifically around medication, as studies have shown, an increased level of recognition of professionalism amongst interpreters, and then finally, an understanding that interpreters in the state of Minnesota who receive Medicaid reimbursement will have an understanding of medical terminology and patient privacy laws in particular. So I'll turn it over to Ms. Rosa Talk to talk a little bit about our stakeholder engagement effort. Thank you.
Thank you, Ms. Talk. Please proceed.
Thank you, Anjuli. Madam Chair and members of the committee, my name is Rosa Talk, and I am the Legislative Director in the area of health for the Minnesota Council on Latino Affairs. As a state agency, we work for the people of Minnesota, and part of our role is to listen to our constituents' most pressing issues. Out of 300,000 Latino Minnesotans in the state, about 194,000 residents aged 5 or more speak a language other than English at home, most often Spanish, but also indigenous languages, especially in greater Minnesota. So this bill, as my colleague Anjuli was referring to, emerges from many voices across linguistic and cultural communities beyond our respective constituencies. We've worked on this bill for the last 3 years, and we have engaged, informed, and held conversations with many stakeholders as possible to gather recommendations, input, and feedback. And those stakeholders include community members in the metro and rural areas. Our agency conducted 24 community listening sessions in the summer of 2017 and 18, and that includes conversations with other constituents, such as this Eritrean refugee patient in Worthington, or a South Sudanese certified interpreter in St. Cloud. So we try to also reach out to these other communities. We have also talked with associations representing interpreters, providers, and community health clinics, including some Somali public health workers in the metro area. Also, owners of small interpreting agencies, including one in Wilmar. Interpreters across different cultural and linguistic groups, representatives of immigrant communities like the Black Immigrant Coalition and the Multicultural Immigrant Coalition, and also multicultural groups like the Department of Human Services Cultural and Ethnic Communities Leadership Council and the Minnesota Department of Health Metro Immigrant and Refugee Health Network, and as well authorities at MDH and DHS.
Thank you. Ms. Talk, we did notice that we wanted people to be limited to 2 minutes because the author has requested your testimony. We gave you some latitude. We do have some people who express concerns. I have Ms. Rachel Hearing as expressing concerns. If she is still here, if I could have her come up, and members, I'm trying to go down the list in order of notice to the committee and find a couple of people with concerns so the committee gets to hear that. I mean, no disrespect to those who have prepared affirmative marks. Welcome to the committee, Ms. Herring.
Thank you, Senator Benson, Madam Chair, and senators. I actually have the goal to speak very much in favor of this bill in terms of doing something, and I'm taking you have in your packets a 5-page thing that I gave you. I compressed that. I'm compressing it even further on the fly, so I hope you'll forgive me if I'm a little inarticulate in that sense. But I am actually here to speak to you very much in favor of doing something. As my colleagues have said, this is something that we've been trying to do for a number of years. Interpreting is a very necessary thing, but it is also a very complex skill. And the folks that are providing these services are providing services to the most vulnerable members of our community. But to do so, I feel, based on my background and training, which I will not go into detail of here, you have it in your packets, that it is extremely important that we ensure that the people who are helping some of our most vulnerable citizens to get access to care be assured that the people who are helping them to get that access are well trained, are able, and are competent to do the job that they are doing. I won't go into the details of all the things that interpreters have to do. I wrote that down for you, but I do believe it's important that in the work of ensuring meaningful access to high quality care for everyone, we need to get into place an effective system that ensures that the people that are providing services are competent.
I need you to tell me the problems with the bill. You expressed some concerns, so what's missing?
I personally believe that one of the biggest things that is missing from it is some kind of recognition of a level above 40 hours of training. I teach in a college-level program, and in fact, several of my students are here, and one of the concerns that we have is that there's no incentive to do more than 40 hours of training, so that might be added.
Okay, thank you very much. As I'm going down, I'm looking for folks who registered to speak against. I have A.K. Hassan from the Minnesota Interpreters Network on the list. If he is still here, if you could come to the table and address concerns with the bill. We are generally familiar with what interpreters do and how important they are, but need to hear concerns. Welcome to the committee. State your name and proceed briefly.
Madam Chair, members of the committee, my name is A.K. Hassan. I am with the Minnesota Interpreters Network, and specifically mostly Somalians and also all Africans. For the past 6 years, this bill was struggling to pass. However, we, the African community interpreters, was left out every session, every time. We only noticed the last minute for this bill, which was drafted, as you can see on the papers, on January 14 this year, and we find out a week ago. So our voices, opinions need to be heard loud and fairly well. We believe this bill needs to be rewritten and be inclusive for all voices. Thank you.
Thank you. And one more person to speak against Ms. Isabel. I'm going to butcher your last name, Montanez. If you're here, Upper Midwest translators and interpreters, significant issues with the bill, if you would address them for us. Welcome to the committee.
Thank you so much for taking us. My name is Isabel Montañez, and I am UMCHA president. UMCHA is the Upper Midwest Translation and Interpreter Association, and our mission is to provide quality and professional care and training. We are looking to have a professional quality registry to include all interpreters of all languages. But we do need to start with training, education, and to have background checks of people that are in contact with patients. Like Rachel said, we are in contact with vulnerable people. So we do ask to add that this be done in a face-to-face interpreting. Face-to-face interpreting is the best practice and is for the best interest of the patient. And there's a fee that most interpreters do not have a lot of money to pay, so we want to keep the $50 per year plus no late fees on this bill. I appreciate your time, and we hope that you pay attention to our requests.
Thank you very much. Members of the committee, questions for Senator Wiklund? And Senator Wiklund, I know you've done a lot of stakeholder engagement, and I'm sure now that this language is moving, there will be more. And so I thank you for your work. And seeing no questions or concerns from the committee, Senator Wiklund, to your bill.
Thank you, Madam Chair. Yes, I'm certainly open to more discussions, and we'll be happy to take feedback, and we can work on the bill from here. So I would, yes, I would like to support moving the bill, Senate File 875, recommend to pass and move to judiciary.
Judiciary. Senator Wiklund moves that Senate File 875 as amended be recommended to pass and sent to the Committee on Judiciary. All those in favor say aye.
Aye.
Opposed? Thank you, Senator Wiklund. You are on your way. Thank you.
Thank you very much.
And thank you, members, for your patience. We are adjourned.